Hello, everybody. We have a very interesting case just to show you. That's our routine. It's important because you are going to see the routine and Dante from ACS patients.
This is a 65-year-old gentleman. As clinical presentation, he has anterior STEMI, which underwent thrombolysis on June the 2nd. From that event until today, he's asymptomatic.
Okay.
Risk factors for coronary disease: he has hypertension, dyslipidemia. His labs: he has a preserved renal function, and he also did a transthoracic echocardiogram, which showed an EF of 34% with apical and anteromedial akinesia.
So he has low ejection fraction.
Low ejection fraction. But by the EKG, it appears that did not succeed because he has Q waves in anterior leads, as you can see. Here is the angiogram that he performed a couple of days ago. And we can see his RCA is a dominant vessel, diffuse disease in the mid portion of this RCA, some mild disease in the proximal segment.
So no culprit lesion with 70% lesion.
About 7%,
Okay.
no culprit lesion. In the left system, we can see here in the RAO view, it calls the attention that his left main looks like a little bit, the diameter is a bit less than what you would expect for a if you compare the diameter of the proximal LAD and the circumflex, but no significant disease observed.
So what is the percentage of lesion would you classify this?
Here in this view, maybe 30%.
30%.
30%.
In the LAD or in left main?
In both. In the distal left main and also at the proximal LAD.
And that could be the culprit lesion for the acute.
By the EKG, it looks like to be the culprit lesion, but we don't see any major signs here of a significant stenosis.
Just confirm that the LAD is the culprit vessel.
Yes, no doubt. By the EKG and the LV-gram, yes.
Okay. You're invasive cardiology. You're here doing this care, anatomic, I would say. Would you go and do a procedure in a patient like this? You stop, or you stop and think and do it? Many doctors do ad hoc procedures.
I stop. It's necessary to see if right coronary artery causes ischemia. In the left coronary. The left main lesion in angiography is about 30%.
30%. Would you do a further investigation with it, with IVOS or even FFR? Functional evaluation.
Functional evaluation is better.
So Ricardo, they asked for a physiological study first. Maybe you can have both here. So
this is acute case. This is not a chronic disease. This is acute case. And when we deal with these patients, we always want to know what's a culprit lesion. And I think that in the past, we'll just go ahead and treat the culprit lesion, regardless if it was significant stenosis or is a ruptured plaque or if it's not. Nowadays, I think this paradigm has been challenged. And here we have a case that it's clear the culprit lesion is a proximal LAD because the EKG, the LV compromise, but it's a very mild disease. So what to do is imaging that we can identify and maybe has some, let's say, objective measurements that we can take and information to say, okay, I have to treat that with a PCI, or to do physiology. Physiology is not indicated if you are in the first week to identify the culprit lesion or to assess the significance of a ischemia.
So, but we are in 3 weeks now.
But it's 3 weeks now, so that could be applied as well.
Okay, good. So what have you done so far, Ricardo?
So what we have considered to do is first to have a physiological assessment, not only for this potential culprit lesion, but we also have some doubts about the significance of the lesion in the RCA. And there's a new system that we are now using in a routine in this hospital that allows us to do physiology by angiography. We don't need a wire to go there.
Okay, we live only with the angiography.
This system is called the MiFR, with this software that is very, very accurate to the contour, to detection the contour of the vessel, and to give you the assessment of each lesion, each segment within the coronary vessel. This is how it was done in the RCA. So maybe Lou, you want to comment here?
Yes, Fausto. So we do the angel, and you just have to use a computer, a normal computer, with the software, and you can do almost like a KCA, and you can do the measurement.
When you see the deflect of the curve, that's exactly where the stenosis are, and you see the color code. You see the blue in the right extreme left. That's no significance in terms of the ischemia. But as you move towards the stenosis, then you see the color becomes green and then yellow and then red. Basically, by the angiography, the acquisition, and also by artificial intelligence.
So it is AI.
It's AI.
AI, okay.
That feeds the system as
So
well.
everything is AI. This is going to be helpful.
That's going to be very helpful. So
Okay.
we can understand what's the significance there, and you can actually move the cursor, right, Louis? You can move the
Yes.
cursor throughout the segment
Okay.
to identify if you have significant stenosis or not.
The result was is in the FFR, so you have a panoramic. So in the distal portion of the right coronary, you have 0.75.
Okay.
And if you see, it's almost like a pullback here, Fausto, because if you do go before when it's blue to the red, you see there's how can I say jump, you can do the measurements on each segment. So that's
So
2
the
hours.
FFR now, I would say, well, that's MFR is
MFR.
0.75.
It's
0.75.
0.75.
Who makes this system?
So it's
There's no advertisement, so you can tell us.
yeah, this system, it's a company based in China. And the good thing is that only by angel. So we did the RCA.
Okay.
So we also went to the left main. And
Inappropriate.
we did, the left system, we did the measure in the LAD. You see here how the system recognizes from the left main up to the distal RCA, recognizes all the side branches. And this is the beauty of this system, because with AI, it keeps, becoming more refined and more consistent.
So Ricardo, what have you done?
So,
So the decision is made. We don't need to treat the left main.
by ischemia, no.
How
But-
about if you want to see like another image?
yeah, but
For example,
many,
Ivals.
I think it's still debatable to some extent what to do with the culprit lesion. So we use here imaging as well. We did angio. Can I have the angio, please? Here you can see the left system. I would say less impressive, the left main. Mild disease in the distal left main, we can see here. And in the proximal LED is really a very mild disease. This is a sign of a culprit lesion, a ruptured plaque, but without significant compromise of the lumen, at least by
even
angio.
the flow.
Between the two
Yeah.
diagonal
Okay.
points.
So you have this by angel, you don't have eyeballs in the room, and you see that. Do you think we should treat this lesion?
No.
No.
We started here in the mid LED. This is about 3.3 vessel. We already see some disease, some degree of calcification, but without compromise of the lumen. That's when you start to see the plaque. You see from 11 to 2, and you see the signs of the ruptured plaque there, but
Even in a calcified vessel, huh?
a calcified vessel.
You have the rupture.
Yeah, but no significant compromise of the lumen. You see the left main, it is a disease left main, no doubt about that. It should be a much larger as you compare to the proximal LED, but with a lumen, I would say, preserved. That's when you start to see the plaque, the calcified plaque from 10 to 1 next. And here you see the minimum lumen area about 5.3, so much more than that number of 4 millimeters square next. So you can see like exactly where we see that flap by angio between 12 and 3 o'clock. So this plaque was definitely the one that caused the acute event.
Okay.
Here we are at the left main, 5.7 millimeters square. We have a diseased left main. There's a centric plaque. The area is about 5.6, 5.7. If you look at the data, it appears to be a stable plaque. This is not a culprit lesion.
That the rupture occurred in a non-severe plaque. So what are you going to do now?
So I would suggest that Louis shows now the MFR. This computer is inside the cath lab.
Inside
it's integrated
Uh-huh.
with the system.
Uh-huh.
So once you acquire the angio, you already have the images in the computer, and you can
Okay.
select the image That's what Louis is doing
Okay.
right now.
Let's see.
Yeah, so he recognized the vessel here, false, and you can choose the frame that you wanna. You can do the measurements. So
you see, folks, how good is this vessel contour detection?
Oh, yes.
It's very, very consistent.
Everything was automatically.
Yes, everything. You just have to select the segments, the proximal and the distal points, and then you already
will do
have
that.
automated
Yes.
selection.
So the
automated
red
detection.
and the blue.
Exactly. And this automated detection already recognizes the trace of the vessel.
doing the contour of the vessel here, Fausto,
Okay.
that the machine did automatic, but I'm just correcting something
Okay.
here, so just to be how can I be more
Okay.
precise, né? And he will do the measurement, so it's automatic. So
Now
now
the measure is going to come
It's
now.
processing.
yes,
Processing. Okay. So this is AI.
This is
Yes,
AI by AI.
So this is 0.73.
0.73
yeah. So
distal vessel.
if you
Yes.
follow me here, Fausto, you can choose the point.
You can navigate.
Yeah.
Okay.
So that's the
Throughout the
pullback
vessel.
they were saying. You can see the numbers.
It's
here.
incredible. Yes.
Oh, it's 111
Yeah.
999.
Oh,
So that's
that's absolutely
That's a
great.
drop.
So this is a 75.
Yes.
Okay,
Yeah,
okay.
yeah.
You are the lesion now.
Yeah.
So distal to this lesion. Can you go down a little bit, please?
Yeah.
That's
Okay.
where you see the
Yes.
drop.
Yeah. You start seeing the ischemia.
Yeah.
Yeah.
I mean, that's an absolutely great
And
demonstration.
here you see in already
Yeah.
orange and red
Yeah.
distal. It means that all that segment from this point.
So it becomes red.
Yes.
Yeah.
It's a great
So,
demonstration, guys.
And
like
It's going to be part of the diagnosed.
part
Exactly.
diagnostic procedure. Exactly. Yeah.
the routine.
So what are your plans now? It's to treat the RCA.
Yeah. So now we're planning to go with the RCA. So here Rodolfo is advancing the wire.
Or the guiding catheter, it's a JR4.
You see the lesion here in the mid portion of this RCA.
Okay.
Here's where we did the MIFR. And we also did another one that looks even worse here.
So it's a large vessel
Very,
distal.
very centric lesion,
Yeah.
as Rodolfo mentioned.
So did you cross with the guide wire?
Yeah. So
Yes, we are just about to cross.
How long is the wire tip? 30 millimeters?
Yeah,
30.
Can you explain us what the stent length you're going to use?
yeah, so here is 30 millimeters. I think 30 millimeters fits very well because we have good landing zones by Angel.
Uh-huh.
And of course, we have eyeballs here we can use to control the results, but I think we do have some mild disease in the proximal segment that we don't intend to treat.
Okay, good.
So maybe a 3.5 by 30.
So we cannot forget there is a severe dysfunction in the anterior wall, and you're going to treat the contralateral. So you're going to do a direct stent implantation or predilation?
I think predilation here.
Also,
Non-polymeric
and I
wire.
have some difficult to dip the wire.
So you're going to use the balloon to get a better support of the wire.
Plate
So what size of this balloon?
It's
30 20.
by 20.
By 20. So you're predilating the lesion.
And you see how the wire now goes very deep in
Mhm.
because of this technique.
Okay.
So now you're much safer to advance a stent here.
What size the stent you're going to use, Rodolfo? 3.5?
Maybe
Just the
28,
band.
real by 28. or 29.
3.5 by 28 was the decision here. So what kind of stent you were going to use at this time?
So we're using here is Inspire stent.
Inspire stent,
Inspire stent.
the Brazilian stent.
So it's a low profile, about 70 microns. It's a PLA-based biodegradable polymer.
What's the Rolamos?
Sirolimus, low dose.
I mean, it's not advertised, but it's a Brazilian stent.
Those used.
Inspire
So now they're going to deploy it.
Okay.
I think they're good landing zones. There's some dissection distal due to the predilatation,
Uh-huh.
but I think that's a good position. We like to do like in the nominal pressure, but don't
Okay.
overexpand and just
You went up
post
to
dilate
8 atmosphere,
7.
7 atmosphere. So you're going to post dilate with a 3.5 by
5 by
20.
20, yes. To do balloon post dilatation.
Yes.
So the stent default, I think is perfect. I think it's nice. I think it's well positioned, good landing zone. Now the question, there's this disease proximal. By Angel, before we started, it was not significant. But once you put a stent, sometimes you're more likely to try to get a result throughout the segment. I think that's a decision to be made. There's no right and wrong here.
Accordion
Yeah,
effect.
on your effect. I think that's a little
I
bit
was
there.
missing this word.
Spasm, yeah.
We are going to do another analysis and a physiological analysis now.
0.97.
So it's a 0.97
Yes.
distal now. So this is stent segment,
Yes.
go distal 0.99.
Yes.
That's perfect. There is no ischemia at this point after you treat the lesion.
This is just amazing how you can control the result of your procedure on
Immediate
time.
on time.
Yeah,
That's
immediately in the cath lab. So we are distal to the RCA. We're going to start the pullback here. Lumen is about 3x4, 3x5. Some part of under expansion there. We just saw here the dissection behind the struts that was caused by the predilatation. As we come to the proximal segment, I think there's room for optimization here of the expansion. Here we just saw proximal dissection of the vessel, so yes, I think you should stent in the proximal part. The culprit lesion has been well treated in terms of the segment, the length. There is room for optimization of the expansion because the vessel is really large. And maybe a 3.5 balloon, I think will be okay.
You are going to cover that proximal dissection, Rodolfo, for another stent?
Yeah.
Okay.
3.5.
Another
12.
29?
Well,
They are going to work and they're going to place a proximal stent and where we got that small dissection.
So we deep in here, intubating here, the guiding catheter.
Now you have another stent at
3.5.
3.5. So you are post-dilate with a 3.5?
Yeah.
3.5.
3.5 by 20. Do you have on the table or not?
Yes, we're going to ask you.
So we're advancing here now, 3.5 by 20. The post-dilatation is very important to do
So
this.
you ran up to 25, 26 atmosphere,
26.
Louis?
26.
26.
And we're getting ready here for another IVUS run.
Okay.
Perfect.
Okay. Can you measure the MFR there
Can
with
you do
this?
the MFR again?
Yeah.
He's measuring again after the second stent. So it's
But
97, 90.
yeah,
Okay.
yeah.
Then in this point, you have the guide wire or some spasm or something like this.
He thinks the guide wire is a vessel.
And now you have a normal FFR in the whole segment.
Yes.
So it's 0.97. Is that correct?
Yes, 0.97, yes.
Okay. Can you correct this where the guide wire is or not?
Yes, I can.
Just to confirm this. And when Ricardo, do you have the image?
We do
Okay,
have the
can you
image.
go to the IVUS image
Just
now?
started.
And you show this later, please.
Just started.
IVUS, okay.
So just started is much better. That under-expanded spot at the distal portion now is solved. You see much better fit to the lumen size. Apply here according to the lumen diameter, reference lumen diameter. Throughout the entire segment, we see a uniform expansion, a much and adequately sized stent area to the vessel size. The area, it's really well preserved. We're coming close to the ocean. Okay, here, we're just by the ocean.
Okay.
It's just perfect position.
Perfect in the ocean.
One strut out.
Okay.
That's how you want to do it. So I think we're very satisfied, Fausto,
Okay.
with the result here by IVUS, and we can do a final angio acquisition. Maybe we can
Yes.
do. So
We are
here we are
doing
in the
the
LAO
acquisition.
control.
Great.
It's beautiful result.
That's a beautiful result in
What
this
you see here, some
huge right coronary
huge
artery.
right dissection behind the struts because that's normal. That's gonna
Uh-huh.
heal. But huge vessel, very uniform, very good
Okay.
result by IVUS.
So,
We are very happy with this result.
okay.
Before the
Ricardo is so
final
anxious just to show it's 0.99. So since the beginning, you see, since the stent segment, you're going to go distal now. So it's a distal vessel is 0.99. So this was a great demonstration, guys. It's perfect. So with this beautiful demonstration from a patient with ACS, that's very common in our hospital, that come from a primary hospital where they were undergoing two lytics. This patient had an MI, came with ACS. The culprit lesion was an LAD that was not severe and was not treated because of the physiology and the IVUS image. But the non-culprit lesion was in the right, in the huge right, that was treated with the 2 coronary stents. And we could show the MIFR. So I thank you so much, Rodolfo, Ricardo Costa, Luis Nakayama, and also Pedro Teixeira, and all the nurses here. Thank you.
Great.
Thank you,
Thank
Medley.
you.
I'll see you next week.
See you.
Bye.
Bye.